Good morning, everyone. I'll start in English and then change to Portuguese. So everyone, welcome to this important meeting with two very distinguished invited guests, speakers for our meeting of this month. The topic and the presentation of the speakers I will leave for Dr. Livia to do, to whom I pass the conduction of this meeting right now. Livia, please go ahead.
Thank you, Professor Manfro. So good morning, everyone. I'm Livia Goldreich. I'm a cardiologist from the heart failure transplant program here in Hospital de Clínicas Porto Alegre. We're very pleased to have you all joining us for our monthly webinar from the multi-organ transplant service here in our institution. And this time we really planned in discussing more in depth clinical pharmacy in transplantation, as we really, as we were just talking briefly before, we really believers that is one of the key points to really improve multi-professional care for our transplant recipients and improve outcomes in several ways. For this activity, we'll have two speakers. We have Professor Mary Lake, who's a pharmacist program coordinator from the solid organ transplant program, and also clinical assistant professor at University of Nebraska Medical Center College of Pharmacy at Nebraska University. And then we have Brazilian experience from Yasmin Cardoso Drake, who's a pharmacist graduated on the University of Oswaldo Cruz. Is also a master's student in nephrology for the Federal University of São Paulo, and is a clinical research coordinator at Hospital do Rim in São Paulo. So I think we'll have the speakers to talk about 15 or 20 minutes each, and then we will open for a panel of discussion, and then everybody will be more than welcome to make questions and comments. We're really trying to learn about different countries and different setting experiences to really try to improve the clinical pharmacy in our program and also in our transplant care. So, Mary, if you want to share your screen. Perfect. Thank you.
Can you hear me now?
Yes, we can hear you.
Can you see my screen?
Yeah.
Okay. Well, thank you for the opportunity to speak with you today. It's an honor to be invited. And today I'll be talking about the role of the clinical pharmacist in transplant programs at various U.S. institutions, including my own at Nebraska Medicine. My objectives are fairly simple. I plan to just describe the role of the clinical transplant pharmacist from the United States perspective, but then also share my experience here at Nebraska Medicine. So in the United States, transplant programs are accredited by various institutions, and a couple of those bodies include UNOS, so the United Network for Organ Sharing, and the Centers for Medicare and Medicaid Services, or CMS. And they require the role of a clinical transplant pharmacist or a pharmacology expert to be part of the multidisciplinary team in order to meet accreditation standards. And that's just evidence that the importance of pharmaceutical care has on our transplant recipients and our transplant donors. And the responsibilities of this individual include both the preoperative setting and the postoperative setting. And due to these accreditation standards, the American Society of Health System Pharmacists, or ASHP, a pharmacist organization in the United States, put together a set of guidelines for pharmacy services on solid organ transplant in 2020 in order to better describe what are best practices for transplant pharmacy services to ensure consistent care across programs. So I'll spend the next time going over some of what those guidelines share, and then I will speak to my personal experience in them. So within the guidelines, the transplant pharmacy services cross the continuum of care. So this includes patients in the pre-transplant setting, the perioperative phase, and the post-transplant phase and ambulatory setting of care. In our pre-transplantation phase, this includes the initial assessment of the patient and any reevaluation that may occur during the waiting list period. And the transplant pharmacist is going to assess pharmacologic risk on two different fronts. First, it could just be any medications the patient might be taking. So these are things like anticoagulation, drug interactions, medications they may be taking for chronic pain, any issues they have with drug absorption, or potentially the use of herbal supplements. But the other pharmacologic role would be looking at immunologic risk and deciding what induction selection is appropriate, or do they need desensitizing therapies. I personally have had experience in discussions on induction selection as well as desensitizing therapies, both at my training program as well in my current practice. The other aspects that we consider are medication adherence. We know the importance of medications after transplant for the success of the graft, and thus knowing it beforehand, knowing how these patients will take medications can enhance their care post-transplant. And then we work with our multidisciplinary team to develop a mitigation plan. We can make most people successful with taking their medications with the appropriate amount of education, appropriate resources, financial assistance, in order to ensure success in the transplant and post-transplant sessions. As we move to the perioperative phase, transplant pharmacists work with the healthcare professionals involved in all settings. This includes helping with seamless medication use process, provision of transplant medication education, and discharge planning in each transition of care. And our institution, this is a high role that we have seen transplant pharmacists be involved with, ensuring that patients are getting the optimal pharmaceutical care. Participation in multidisciplinary team rounds is quite common in the United States. And then ensuring that medication access and planning for discharge are also key components of this phase. But as we know, transplant doesn't end with the transplant surgery. And as the patient focuses into the post-transplant phase or the ambulatory setting, we continue to have a role in direct patient care, helping manage graft function and manage immunosuppression and executing protocols. At my institutions, I've seen this involvement in dose modifications of immunosuppression, in optimization of immunoprophylaxis based upon patients' risk factors, as well as management of CMV and other disease states post-transplant. Now that's what the guidelines say. In real-world practice, let's take a look at what we actually do. So in 2015, there was a national survey of accredited U.S. transplant programs asking for what is the role of the transplant pharmacist in institutions. And so 278 transplant centers that are listed in UNOS were reached out to, and about 132 centers responded with 176 individuals. Most of these individuals were from larger transplant programs in the United States. So the smaller programs weren't quite as representative in this survey, but this will give us a picture of what it looks like for a transplant pharmacist in the US as of 2015. So again, they focus on all these different phases that I've already mentioned. So starting in the pre-transplant phase, you can see that a good majority of pharmacists are playing a role in medication review and med allergy review. I see this on a regular basis, looking at patients who have penicillin allergies, and I need to modify their infection prophylaxis going into transplant surgery, or potentially a sulfa allergy that would require a different infection prophylaxis for PJP. But other roles include that post-transplant immunosuppression. Should this patient receive induction? Should this patient be on tacrolimus, or should they be on cyclosporin? Or would belatacept be a more appropriate agent? And so being involved in those conversations early on allowed transplant pharmacists to ensure care is consistent in the perioperative phase. In the United States, the perioperative phase will break down to two sections. We could have our initial transplant event and our readmission after transplant for those that have already received a transplant. As you can see, in the US, the transplant pharmacists have a varied role in terms of whether they're being involved in that readmission process. So most transplant pharmacists are seeing the patients during their initial transplant hospitalization, but not all of them are seeing them during readmissions. And this is likely due to center practices. So depending on the size of the center may not readmit a transplant patient to their home service. And so they may go to an internal medicine service or another service line that a transplant pharmacist may not be actively engaged with. At my center, we often readmit back to our service, but for those patients who have complications that are unrelated to the transplant, they will end up on an internal medicine service. And then I'm providing more just immunosuppression support rather than comprehensive medication care. But again, the medication review and lab review are key elements across the centers. And then recommendations for both non-transplant medications as well as immunosuppression occur with those bedside team rounds being quite common. I would say in my practice, it's very common for me to address all areas of the patient, from diabetes to hypertension to pain management, in addition to the immunosuppression process. In the post-transplant setting, you can see that we don't see the same percentages that we see in the perioperative phase. And I'd like to point out that this was in 2015. In the last 8 to 10 years in the United States, the role of the transplant pharmacist in the ambulatory space is continuing to increase. So I see this at my center, and when I talk about Nebraska medicine, we've exploded in the ambulatory setting through involvement with provider status or collaborative practice agreements. But again, playing a large role in medication review in the post-transplant setting. And as transplant pharmacists, we never should forget the importance of transplant medication education. Medication importance after transplant never goes away. And sometimes patients need a nice reminder of how to take their medications or why they're taking them, just to ensure consistency and success for the graft. But the role of the transplant pharmacist doesn't stop with just those phases of care. The transplant pharmacist can be involved in a variety of other tasks, and these are what the guidelines recommend. So involvement in key patient populations, such as pediatric patients. Our pediatric patients can be at a high risk as they transition from pediatric to adulthood. So at Nebraska Medicine, we have a pharmacist that helps with the transition of care from the pediatric population to the adult population. Pregnancy is also a high-risk situation for our transplant recipients. And as we have successful graft outcomes, likely we'll experience more and more patients who become pregnant and want to start their families. Not all immunosuppressions are safe in transplant, and transplant pharmacists are situated to be able to help in this situation. And then other comorbid disease states are quite common for transplant pharmacists to be involved in, including things like hypertension, diabetes, hyperlipidemia, and the like. Given the regulatory demands of transplant programs, it is quite common for transplant pharmacists to have high administrative responsibilities, and this involves contributing to quality measures. In the United States, we have a program called Quality Assessment and Performance Improvement, or QAPI, and pharmacists are actively engaged in those across institutions. I know pharmacists personally that actually are the heads of QAPI that for their institutions. Other roles are formulary management. I do this on a daily basis, or maybe not daily, but quite commonly. Recently, we added a new medication to formulary that will help in our pre-liver and our hepatorenal population. But that's something that we can play a role in to ensure appropriate and adequate use of medications. One area that I think is really exciting for pharmacists is the development of collaborative practice agreements, or in states that have provider status, where the pharmacist can actually prescribe medications under the guidance of a physician that allows for the providers to have extended time and focus on other things while the pharmacists manage the things that are within their skill set. And lastly, medication use evaluations are quite common amongst transplant pharmacists in the United States, as they look to ensure that medications are used appropriately and managed well. And lastly, professional development is encouraged among transplant pharmacists in the United States with clinical research and publication, engagement with transplant organizations such as the American Society of Transplantation. More recently, the Board of Pharmacy Specialties recognized solid organ transplant pharmacy as a specialty. This was in 2018. The first exam was in 2021. And so the Board Certified Transplant Pharmacist, or BCTXP, came into existence. This is an international test. So this is not meant just for the United States, but this is something that can guarantee or ensure that the minimal standards of understanding of your transplant pharmacist are being identified and observed. And lastly, the pharmacists here play a large role in education and training of the next generation of both pharmacy students and pharmacy residents. Going back to the survey, you can see these actions are very common in our cross centers, with almost all pharmacists responding to this survey being involved in protocol development and order set development. I think it's incredibly important for the pharmacists to be at the table when discussing changes to immunosuppression, plans for infection prophylaxis changes, as the pharmacist is often the one that's helping to ensure the implementation of those protocols. And so being at the starting table can help ensure that effective and safe care is being provided. Now, how a transplant center in the United States exists will really be dependent upon the center. So this often depends on the number of transplants that are being done, as well as the transplant pharmacist. I gave you a lot of things that are the roles and responsibility of transplant pharmacists, and one transplant pharmacist can't do them all. And so the center has to determine which ones are the most appropriate for the patient and develop minimum standards that they expect at their institution based upon the supply and demand of those transplant pharmacists. In the US, the coverage models can differ. So some pharmacists only cover outpatient situations and some cover only inpatient, and there's not a rotating in between, but other programs will have those pharmacists rotate between the inpatient and outpatient, either on a monthly basis or some even on a daily, where I'm in clinic in the morning and I'm on rounds in the afternoon. And then every center is different in terms of whether or not you're covering just one organ or you're rotating. It's quite common for above and below the diaphragm. So a transplant pharmacist may cover the heart service and the lung service, or they may cover the kidney service and the liver service. But there are centers that I know of, they cover all of those rotating organs. And so a lot of this has to do with the size of the center, the volume of the programs, and whether or not the centers can support a specific pharmacist for a specific organ. So taking a look at Nebraska medicine. When I started in Nebraska medicine, it was 2015. We had 5 transplant pharmacists in addition to a transplant pharmacy resident. Each organ had its own transplant pharmacist, including a pediatric pharmacist that focused on our pediatric patients. These pharmacists could provide inpatient service support, including bedside rounds, verification of orders, coordination of discharge planning, and then we were available for outpatient needs as needed. We weren't going to clinic very consistently. It was a very, there was only a few of us for the organs, and our volumes were such that we were primarily focused on that inpatient or perioperative phase with more cognitive support in the preoperative and post-transplant setting. In the last 5 to 10 years, this has changed dramatically. And as you can see, we have nearly doubled our transplant pharmacist size at Nebraska Medicine. Each organ of kidney, liver, and heart now have 2 transplant pharmacists dedicated to those roles, with one primarily focused on the inpatient service line and one primarily focused on the outpatient service line. And a lot of crosstalk is happening. The pediatric pharmacist does both inpatient and outpatient, and that's just due to volumes. But we've also added an adjunct transplant pharmacist that can fill in where the needs are to, if a service is very heavy, they can jump in and help with evals or inpatient verification or discharge planning. And the lung transplant pharmacist, due to lung volumes, is also a pharmacist that covers inpatient and outpatient. When I talk to my upper management about what transplant pharmacists do, this is an image that we will show. And it shows all those phases of care in addition to the regulatory and compliance aspects. The pre-transplant and post-transplant areas are where I see most of the involvement with our ambulatory pharmacists, those that focus primarily in the outpatient setting. They see patients at evaluation as well as at wait list, evaluating medication regimens. Where I practice primarily in the perioperative space, and that's where I do order verification. I round daily with the physicians. I meet with patients individually and provide education. I do discharge education, including filling a pill box and making sure that those patients have what they need to be successful post-transplant. In the post-transplant setting, we see patients in clinic. There's a pharmacist that specifically goes to kidney and liver post-transplant clinic and provides support where needed. When patients are readmitted to the hospital, I will see them post-transplant and provide cognitive support. In the post-transplant setting, we also have collaborative practice agreements that allow for the pharmacist to manage things such as steroid-induced hyperglycemia, electrolyte management, prednisone tapers, and the list is continuing to grow. And lastly, all of our pharmacists are involved in policy and protocol development, regulatory demands, as well as pharmacy education, residency training, and research and professional development. And so this, the inpatient clinical pharmacists also partner with our retail pharmacy to ensure medication acquisition, prior authorization is completed, copay optimization is done, and free drug access is provided when needed. The nice thing at our institution is we have pharmacy financial counselors, and the pharmacy financial counselors are pharmacy technicians that are able to help with prior authorizations so that the pharmacist or the transplant pharmacist can focus more on the clinical extension of care. Where do I see us growing in the next few years at Nebraska Medicine? Well, we're anticipating further expansion into the ambulatory clinic space in both the pre and post-transplant settings. Kidney transplant is expected to add an additional transplant pharmacist in the coming year to help with managing evaluations as well as manage these patients long-term. I anticipate collaborative practice agreement growth as well. Our first collaborative practice agreements happened about 5 to 8 years ago. And we started with just a few items. And once we started helping in certain areas, the hepatologists are, can you take this? Can you take that? Can you take this? And want us to be more involved in that. So I anticipate that will continue to grow in the coming years. And then my desire is that we'd have continued engagement in clinical research, always looking to ensure that our care is safe and effective for our patients and optimizing it for them. And then professional development. I currently am the vice chair of the board, the BCTXP, or the Board Certification for Transplant Pharmacists Specialty Council. So I help set standards for what it means to be a transplant pharmacist. And my hope is that our staff will continue to be engaged in really elevating the practice of transplant pharmacy. So my final thoughts are that the clinical transplant pharmacist in the United States across the world can enhance the care of transplant recipients and donors throughout their entire process, from evaluation to transplant and beyond. And it's the knowledge and the skills of the transplant pharmacists that position them well to serve as providers extenders through both collaborative practice agreements or, if allowed, provider status, and then also be participating in protocol development and execution. And really the opportunities for clinical transplant pharmacists are immense and endless, in my opinion, as they continue to grow as we advance the pharmacy practice further. To me, it's an honor to be a transplant pharmacist. I love the growth that I have seen at Nebraska Medicine in the last 5 to 10 years, and I'm excited to see what happens over the course of the next. Appreciate your time for letting me speak, and hopefully I didn't go over too long.
Thank you very much, Mary. That was amazing, fantastic overview of the transplant pharmacy in the US, and also your own experience and also efforts, right, to continue to grow the pharmacy importance and activities in transplant. So now we'll have a bit of the Brazilian experience with Yasmin Draghi from Hospital do Rim, São Paulo, and then we'll get the panel for discussion at the end.
I will share my screen. 1 second. Are you seeing my presentation?
Yes. Mm-hmm.
Okay. So Bom dia, meu nome é Yasmin Breis e hoje eu venho apresentar a experiência do farmacêutico no maior programa de transplante renal, Hospital do Rim Fundação Oswaldo Ramos, localizado em São Paulo, Brasil. Eu sou formada em farmácia bioquímica, atualmente sou coordenadora de estudos clínicos no Hospital do Rim e trabalho na área de pesquisa clínica há 6 anos e este ano finalizo meu projeto de mestrado na disciplina de nefrologia da Unifesp. Esse QR Code direciona para a página do meu LinkedIn, meu e-mail também está à disposição de todos vocês. Então, hoje eu vou apresentar o programa de transplante renal aqui no Hospital do Rim, as responsabilidades do farmacêutico neste programa e a minha experiência como coordenadora de estudos. Este ano, o Hospital do Rim ele comemora 25 anos de fundação e durante todo este período, após aprimorar o funcionamento de todas as etapas do programa de transplante, nós atingimos o status de maior centro de transplantes do mundo, realizando mais de 900 transplantes renais desde 2014. Esse gráfico ele representa o número anual de transplantes desde 1998, a fundação do hospital, até o ano passado. Em laranja, nós temos o número de doadores de transplante de doador falecido, e em verde, o número de transplante de doador vivo. E desde 2009, aumentamos a proporção de transplante de doador falecido em relação ao transplante de doador vivo. E além do número de transplante renal, nós alcançamos também um excelente resultado desses transplantes. Aqui eu mostro 2 curvas de sobrevida do enxerto de receptores de transplante de doador vivo e transplante de receptor de doador falecido. Nessa curva mostra a sobrevida cumulativa do enxerto em 1 ano de transplante e em azul aqui eu destaco o início das nossas atividades no Hospital do Rim, no período de 1998 a 2002, no qual nós tínhamos uma sobrevida do enxerto para doador vivo de aproximadamente 94%. E com o aprimoramento de todas as técnicas e processos, hoje nós temos uma sobrevida de 100% de doador vivo. Comparado à sobrevida do enxerto de doador falecido, nesses últimos 25 anos, aqui também trago a sobrevida do enxerto dividido por eras, e atualmente temos a sobrevida de 92% do enxerto para receptores de transplante de doador falecido. Isso significa que 92% desses pacientes chegaram ao final de 1 ano vivos e com enxerto funcionante. E um programa de transplante, ele exige todas essas etapas para o funcionamento. A procura de órgãos, centro cirúrgico, ambulatório pré-transplante, leitos hospitalares e unidade de terapia intensiva, ambulatório pós-transplante, o laboratório de imunologia, o laboratório central de análises clínicas, e o farmacêutico, com a sua formação, ele pode atuar e agrega conhecimento em todas essas etapas destacadas no programa de transplante. O Hospital do Rim, ainda como um hospital-escola, ele conta com um núcleo de ensino e pesquisa, no qual participa da formação de estudantes de graduação, residentes, pós-graduandos, de mestrado, doutorado, pós-doutorado. E há 25 anos construímos uma equipe consolidada de pesquisa clínica, no qual o farmacêutico tem um papel fundamental. A história da pesquisa clínica no Hospital do Rim iniciou em 1998, 2 anos após a primeira regulação brasileira em pesquisa clínica, e nesses últimos 25 anos tivemos uma participação excepcional, nacional quanto internacional, no cenário da pesquisa clínica no transplante renal. E mais recentemente, com a expertise adquirida em pesquisa clínica no transplante, nós expandimos a atuação em outras áreas terapêuticas, glomerulopatias, COVID-19 relacionada ao transplante, reumatologia, nefrologia e endocrinologia. Nós, durante todo esse período, tivemos 122 estudos patrocinados pela indústria farmacêutica e 45 estudos de iniciativa do investigador. Vale ressaltar que 82% do time de pesquisa clínica nesses 25 anos foi e é composto por profissionais farmacêuticos. E hoje eu farei um breve depoimento da minha experiência nos últimos 6 anos, começando pela atuação do farmacêutico nas diferentes fases de desenvolvimento de drogas. E o Hospital do Rim, ele teve a oportunidade de participar da aprovação da maioria das drogas que são utilizadas como regime imunossupressor atualmente. Adquirimos uma experiência com estudos de fase 1, fase 2, 3 e estudos de farmacocinética e farmacodinâmica. E partindo agora para a minha experiência nos clinical trials, o coordenador de pesquisa no Hospital do Rim, ele está envolvido do início ao fim em todas as etapas de implementação e condução de estudo clínico, desde a revisão de contratos e orçamentos de pesquisa, análise do pacote de submissão regulatória para Comitê de Ética em Pesquisa e a Comissão Nacional de Ética em Pesquisa, checagem de critérios de elegibilidade, discussão dos casos clínicos com o time multidisciplinar para a inclusão de participantes em estudos clínicos. Nós, farmacêuticos, também analisamos todos os resultados dos estudos e também acompanhamos todas as monitorias dos patrocinadores e auditorias e inspeções de agências regulatórias. Nós já tivemos aqui no Hospital do Rim 2 inspeções pelo FDA. Em relação aos estudos de mundo real, eu gostaria de compartilhar com vocês um marco da pesquisa clínica no Hospital do Rim durante a pandemia, que a partir de um estudo clínico e com toda a organização da equipe multidisciplinar, foi possível vacinar mais de 4.000 transplantados renais contra o vírus SARS-CoV-2 com a vacina Coronavac, apenas em 2 finais de semana. Então, todo esse time aqui do Hospital do Rim, o time da pesquisa clínica, com todos os farmacêuticos, biomédicos, nós lideramos essa iniciativa e os pacientes transplantados renais tiveram a primeira oportunidade de receber essa vacinação como grupo de risco nacional. E para completar o ciclo de atividades do farmacêutico, o networking e internacionalização de carreira é fundamental. Então, como farmacêutica, em junho do ano passado, eu tive a honra de representar o Hospital do Rim no Congresso Americano de Transplantes, e então apresentar os resultados deste estudo clínico em COVID-19 no Congresso, com a participação de toda a equipe também de pesquisa e contato com outros pesquisadores do Brasil. Na próxima semana, inclusive, eu estarei novamente no Congresso Americano, agora como farmacêutica e pós-graduanda, para levar os resultados do meu projeto de mestrado em pacientes transplantados renais. E em setembro do ano passado, mais uma vez, nós apresentamos os resultados dos trabalhos desenvolvidos no Hospital do Rim, relacionados com a vacinação contra a SARS-CoV-2 em transplantados renais, e os resultados também de projetos em biomarcadores para transplante renal. E nessas fotos vocês podem ver uma parte do time do Hospital do Rim, contando com as maiores lideranças no transplante renal nacional e mundial também, como o Dr. Medina, Dr. Ed Tedesco, Dr. Lúcio Requião, doutora Marina Cristelli e todo o time de pesquisa, contando com a Mônica Nakamura, que é a supervisora de pesquisa aqui no Hospital do Rim. E além da contribuição com trabalhos locais de iniciativa do investigador, também realizamos, na maioria, pesquisa clínica com estudos patrocinados pela indústria farmacêutica. E nesse ano eu tive a oportunidade de trocar experiências com outros centros de pesquisa do Brasil, da Argentina, Grécia, República Tcheca, relacionados a estudos em glomerulopatias que incluem pacientes transplantados renais, o que faz parte da nossa expansão em novas áreas terapêuticas também. Então, as mensagens que eu gostaria de deixar aqui hoje é que você, como farmacêutico, é uma peça-chave no programa de transplante, na assistência do paciente e na pesquisa clínica e acadêmica. E, ao mesmo tempo que o programa de transplante, com a sua complexidade, ele contribui essencialmente com o desenvolvimento profissional do farmacêutico. Como citei nessa apresentação, o coordenador de pesquisa clínica também, ao gerir todos os processos de implementação dos ensaios clínicos, há um ganho imensurável de conhecimento. E o envolvimento do farmacêutico com a equipe multidisciplinar no programa de transplante, o networking e a internacionalização deste profissional engrandece e melhora a qualidade do programa de transplante. Eu gostaria de agradecer a oportunidade, doutora Nadine, doutor Manfro, e agradecer toda a minha equipe aqui do Hospital do Rim da Pesquisa Clínica. Muito obrigada.
Muito obrigada, Yasmin. Realmente muito impressionante, né, o cenário de pesquisa clínica que vocês né, têm construído já e consolidado no Hospital do Rim. Thank you very much for your talk. Now we'll go ahead then with the panel discussion. Everyone is more than welcome to send questions either through the chat or just raise your hand and open your mic. You can send the questions in English or Portuguese, and we'll translate if necessary. To actually start running the questions, I want to invite Paola Hoff Alves and Douglas Norberg de Matos, both who are clinical pharmacists from our solid organ transplant program, and pharmacist Daiane Galato, who's a professor at Brasilia University and working mostly with kidney recipients. Guys.
So good morning, everyone. Actually, before we start, I'd like to give the word to Professor Daiane, who is joining us from outside our community here, our hospital. So, Professor, please go ahead.
Hi, good morning. I am very happy for this moment with you. The presentation are wonderful, and I have a question to begin this discussion. In your opinion, how is the most important from the pharmacist to improve the clinical outcomes during the care of inpatients or outpatients patients?
I think we lost the first part of your question, Professor. Please, would you kindly repeat this?
Yes, excuse me for my internet. The question is, during the presentation, both talk about a lot of actions with the pharmacists. It's possible the pharmacists do during the care in pre or post-transplant, outpatient, inpatients. In your opinion, what is the most important action to improve the clinical outcomes in the transplant?
For both
for both.
Thank you. I think the most important work here at Hospital do Rim, and I think in all transplant programs, is the participation of the multidisciplinary team. Yeah, because only the pharmacist work without the other teams, I think we can do nothing. So to improve the outcomes, we need to share our experience and to contribute. All the teams contribute with the pharmacists too.
I would agree with Yasmin. I think that engagement with a multidisciplinary team regularly allows for strong collaboration. None of us can operate in silos and expect to provide optimal care. And I think as we work together, we can ensure that care is the safest, the most effective. Although I don't understand Portuguese and all of what Yasmin said, what I interpreted based on that is that clinical research is an engagement of the multidisciplinary team, and it's important for the pharmacist to help be alongside as clinical research is being performed. As we say here is that pharmacists are the drug experts. That's what all my training was on pharmacotherapy and how drugs work and how they are removed and used in the body. And so being able to be that resource as clinical trials are developed, I think is a key role as well. So I think the engagement and working together to collaborate and then to extend into our specializations, I think is the key aspects.
Thank you for both your question, Professor, and answers. And about that, we earlier this morning I was reading something about comprehensive medication management, and we all can relate the better care of our patients with a multidisciplinary team. Okay, and we are trying here at our hospital to have a group of pharmacists that actually work together in to bring more value to the patients in a team-based care. But when you bring the discussion to the team-based care, it's important to have the definition of roles of every professional who is working there, like the nurses and the pharmacists. I was very I didn't know that you guys in Nebraska had the one guy that has the does the monetary counselor or something like that. It's a whole that we don't have here. So my question about that is how can we define roles and responsibilities of everyone of the team, so everyone knows what to do and have the standards and have the quality measures and everything that comes together with the right rolling of everyone in the team-based care. If you guys could comment on this topic. Okay, I'll choose Mary. And then after Yasmin, if you please.
I think that a key aspect is actually sitting down and writing out what are the tasks that are needed to be completed, and think globally. Like this can be done in a large group setting of here are all the things that need to happen. We need a transplant surgery. We have to have induction medications. We have renal function changes. We have all these things, and write a very comprehensive list. And then look at your team members. Who on my team is most appropriate to address those issues? So for instance, as a pharmacist, I would say that renal changes, so changes in renal function, is a big part of what I do to ensure that medications are dosed appropriately. I don't look to my transplant surgeon to say, should I dose reduce this medication because of decreased renal function? He looks to me to say, I need to do that. So I think the best way to define roles and responsibilities is to look at all the tasks and then start assigning them as a team. I think as you create a culture that really leans in on one another, you can become very effective, because I know, like, I put in all induction therapy for my liver transplant recipients. My physicians know that. So once we have decided that trigger is happening, they no longer have to worry that I'm going to put in the induction therapy. And so I think that those aspects of the team and building those strong bonds will be helpful as you kind of lay out the roles and responsibilities. That's my opinion.
That was great.
Jasmine, would like to comment on this topic, please? Or, okay.
No, I'm totally agree with Mary. I think the other point, the same point, is to connect the multidisciplinary team. Yeah, and I think we must we have to know and to understand what is the difficult and what is the necessity of the patient too, individually. Yeah.
Thank you very much. Those were great comments, because that's exactly what we, one of our challenges, right, on a day-to-day basis is really to decide on whose task, right, is this or that, and also take responsibilities for, right, the process for taking care of these patients. And that's exactly really the experience that we wanted to hear, because that's what we are looking, right, to really move forward, I think, as multidisciplinary teams taking care for transplant patients. It's very challenging to as a physician, and I'm actually here just doing the physician part, is impossible to do it all, right? And you just don't know it all. You just can't can manage it all on your own, and at the same time, like having, right, people that have the different skill sets makes a total difference on our day-to-day practice. I think we do have some questions here on the chat, and guys, Douglas, Paola, I don't know if you also have other questions, but one of our colleagues from intensive care who works with our group asked, what is your experience with apps for smartphones helping patients to control medications at home?
I'll take my experience. I would say that I don't know if 50-50 is the right word. I think one of the things that you're looking at is like whether the patient is actually tech savvy. So I work in liver transplant, and many of my patients come in with some form of encephalopathy, which can sometimes make the early use of smartphones not as easy as they recover from kind of how severe their encephalopathy was pre-transplant. But I think as we have younger generation and people that are more tech savvy growing up, so those that were the generation after me who are now growing up and requiring transplants, I think their ability to use smart apps will continue to grow. It's very patient dependent on whether they are comfortable with that. We try to encourage from an adherence standpoint, like our pharmacy does have an app for refills and notifications for the need for refills. So I tried to use that as a way to enhance adherence. But I think it's still on the verge. I participate in a medication adherence group, and one of the things we're exploring is like, can we standardize what these smart apps provide so that transplant centers have a very easy go-to place to say this is a good resource, because a patient can say I take their medication and click the button, but we can't confirm that other than their word for it. So I think I encourage it for those that are able to use it, but it doesn't work for everyone based on my experience.
Yeah, of course, Mary, I will say about that because here in our population, there is some patients that is useful these apps, but I think it's more simple. Sometimes you can use only an alarm or a note to record the medication, and I think this point will be helpful depends on the population. Yeah, and what you said, in young people this is more comfortable to use. Yeah, here in our population. Yeah.
Thank you. I think we have another question here. It's actually just on the same this same idea. Our nurse coordinator from the heart transplant program, Leticia, asked about main barriers for medication adherence, how to help patients overcome those barriers.
So again, I think this is very patient specific, but some of the things that I've encountered recently are just communication. So we will transplant patients who are non-native English speakers. And I think sometimes one of our challenges is communicating appropriately what they should be doing, and then for them to understand and then perform those things, as well as the cultural differences amongst different races can sometimes, change expectations, and we're not always fully equipped to understand how we can best serve that population. So I think continuing to be lifelong learners as professionals of how do I engage with those who might have different habits than I do. So that's one of my, currently we're walking through a situation like that here at Nebraska Medicine, but other areas are just forgetfulness, so cognitive decline. And so a lot of times utilizing family support, home health care, especially in transition periods, have been really helpful to enhance patients as they kind of recover after transplant. But that caregiver is so crucial for these patients who often, as they age, might need that additional support. And then in our transitions patients, so patients that are moving from pediatric to adult, sometimes they just want to be a normal kid, or they just want to be a normal, adult going into, child going into adulthood. And so taking medications is not something that they want to do because it makes them different. And I think continuing to have the dialogues with them, following up with them, ensuring that they have the resources and the skills to be able to attain the medications on their own, because many times these patients have been handheld through their childhood to have successful graft outcomes. And now as an adult, they have to take responsibility, and that transition can be quite difficult. So we have a pharmacist who's actively engaged in that transition period, looking at refill history to assess adherence, calling the patient, and making sure that they're understanding the importance. So those are some of the key things that I've seen in my practice.
Yeah, can I share my experience? Here, there are some important moments that the pharmacist follow the patient. For example, at the discharge hospitalization after the transplant surgery. So before the patient discharged, there is a group of pharmacists and nurses that will talk with the patient and the family to instruct all the points and dose and medications, and this is very important. And in outpatient clinic, we have another other group of pharmacists that follow this patient in all visits. Yeah, so I think this close this close conversation and follow up of the patient is important to to keep this patient taking this medication, yeah, because the most successful of the transplant is are the drugs, the immunosuppression.
Thank you. Nadine has raised her hand, and then Professor Manfred.
Yeah, we are old style. We raised the hand. I rose with the thing in the Zoom, and my friend Roberto Manfred just rose his hand.
It's some
like
Zoom lessons.
Yes, I know. It's a gap, a generation gap here. Mary, I'm very curious when you say I put up the immunosuppression. You know, I've been listening to you in the round and imagining the rounds, okay, with the surgeons and the physicians and you name it. And you say, I put up the induction and I put up the changes in immunosuppression because of kidney function goes up and down. How does it work in your daily basis? How the operation of this works? Because there is, of course, differences in countries and regulatory issues, depending on, you know, job description and on all that. So do you guys have prescription orders privilege? How do you really do it on a daily basis?
So for some medications, we do have prescribing authority. So I can do those things within scope. So our institution has built in for renal function changes, for anti-infectives, I can actively do those changes without calling a provider or calling a physician. So those are set, those are written out. Now, if I want to act outside of those because I think the renal function may be better or worse than it appears, then usually that's going to be a conversation that I have during the multidisciplinary rounds aspect. And then we have the ability to modify the orders within the chart and either enter them as telephone orders or verbal orders according to the conversation. So I can actively modify those changes. So when I'm looking at induction therapy, so we'll use depleting agents in liver transplant for our renal sparing reasons. We have set standards of what our cutoffs are for when we choose to use them. So usually what will happen is either the provider will order the first one. So if it happens on the weekends, they may have ordered it already. And then that will then trigger me to put in the subsequent orders done either as a telephone order or a verbal order based upon kind of the conversation that has. So the decision, like we're going to do 6 milligrams per kilogram in this fashion is set up based upon a protocol that we've developed. And so I get confirmation that, yes, we want to do that protocol. And then I will enter the orders and the pre-medications that are appropriate based upon a protocol that we've already built and established. When it's immunosuppression, we make immunosuppression decisions on rounds in terms of when we look at levels of tacrolimus and we modify orders. So I will have a recommendation that I bring. The physician will have a recommendation that he might have, and then we work together to decide what that decision will be. And then I will make the change in the chart based on that conversation as either a verbal or telephone order, depending on how the conversation went down. I know that other centers, the transplant pharmacists have collaborative practice agreements, so they can make the changes independently on the immunosuppression and then document their orders in a chart note. So it would be, and I believe it's maybe the University of Maryland, but their pharmacists have very broad collaborative practice agreements that allow them to modify immunosuppression, and that you can basically hand off to the pharmacist to manage it based on goal level. So if I want a target of 8 to 10 and the level is 7, then the pharmacist would say increase the dose, put the note in. The provider could always go back and change it if they didn't like it, but there is an ability to make those changes. So at my center, I don't do that independently. I do that in collaboration, but I do know that there are centers in the United States that do that independently based upon center practices.
That's wonderful to hear. I know, but I think it's a change in culture that we have to cover grounds in Brazil in order to move towards that. with, I think it's close to the ideal way of working on a truly multi-professional way to take care of those patients. Thank you very much. We'll take notes of that and see how we can go forward with our pharmacists. Manfro, I'm cutting out my mic.
Okay, thank you for both talks, wonderful. My question is regarding to interactions of medications. In your institutions, I believe it's part of the work of the pharmacist to control for that. The question is, in your electronic prescription systems, do you have tools for looking for pharmacologic interactions of the immunosuppressants, which can either improve or decrease their effectiveness?
I'll talk quick, and then if Yasmin has things to add. We do have the ability to have drug interactions. As we verify orders, we'll get pop-ups, so there'll be alerts saying there's this interaction, and sometimes we're like, yes, I want to use that interaction because that's why I'm actually ordering the medication. And at other times they may be insignificant, and I think that's the role of the transplant pharmacist, is the alerts aren't always smart. They are just potential interactions, but may not be clinically relevant. And I think that's where the transplant pharmacist can help ensure that we're interpreting things appropriately. Even yesterday, I had a provider say, I'm doing this and they're starting this. It's flagging me, and I'm like, oh, it's fine, because of the clinical experience, as well as the alert is often global. So it's like saying any magnesium supplement you're starting is going to flag these things. And so this drug has magnesium in it, so it's going to flag these things. So it's not always smart. And I think that's where we can use those and then use our clinical knowledge and experience to really assess the alert. But it's very helpful though, because sometimes, you know, especially when meds you haven't seen for a bit flag, it makes you think a little bit more. But alert fatigue is also a real thing. So sometimes you can ignore things. So you as a practitioner, you have to just take the time to say, I'm going to read through each one of these, even if I think it's just not important, because you'll catch yourselves on things sometimes.
Here we don't have a specific system in the electronic health system to flag, but we have 4 pharmacists that are dedicated to review this all the medications for hospitalized patients. And sometimes if the patient is receiving a specific treatment, there is a kind of flag at the system, but I think it's more manual review. Yeah.
So the last question. First, Professor Lake, thanks for sharing your experience. I am Paola, I am transplant pharmacist here. And I think one of the biggest challenge for us is about clinical outcomes measures, the impact clinical in here. So your opinion, we can start, how do we can start this?
So to clarify, is the question is how would you start measuring clinical outcomes?
How to choose, yes.
Oh, how to choose. So I think that's a challenge probably across the board, because our multidisciplinary teams are so connected. It's very difficult to say that, you know, because I was on the team, that I made those changes that became effective, you know, that made that change. I mean, obviously, as a transplant program, we're looking at graft outcomes. So whether or not we have more or less rejection, how long patients survive. So I think, we can play a role in that management, especially if we're looking at a pharmacist-driven immunosuppression planning. So you would want to be looking at, like, do you see more or less rejections than you did before when a pharmacist was engaged with it? So I think that's one way. From a collaborative practice agreement that we have, so one of the things that we've taken over is vitamin D and calcium management post-transplant to minimize osteoporosis risks. And so one of the clinical outcomes that we'll be monitoring is looking at our vitamin D levels after transplant to assess as a surrogate marker, did the vitamin D levels become therapeutic more frequently when a pharmacist was involved than before. So I think you look at what you're actually doing and then assign the clinical outcome that may be associated to that activity. But it can be very difficult, and we've had these conversations as we've expanded, right? We've doubled our transplant pharmacist volume, and we have to come back and say, we're making a difference, and how we can show that can sometimes be challenging because the changes might be slight. But I think it's also one of the other areas I think plays a role is that is the volumes able to grow? Are providers able to see more patients? Is there a better overall work-life balance among members of the team that allow for success as a team as programs continue to grow? When I look at Yasmin and they're doing 1,000 transplants a year, the idea of doing 1,000 transplants here seems a little overwhelming. But I think that, if you have a team that's structured to support, you can grow to that level with less stress. So I think it's look at the activities that you're doing and think about what clinical outcomes align with those activities and monitor that.
Thanks.
So I think we're at time already. So I want to make a last comment on behalf of all of us, our team, transplant pharmacists on Solid Oregon. And we are very delighted with your explanations and to have the opportunity to hear how the things are being done outside our little castle, how you say here. And I would like to say that we are feeding this strain that is coming from our administrators, and we think we're growing right in here too. This meeting means this. So by that, I'd like to thank Dr. Nadine and Dr. Olivia for the opportunity. And for if depended only on us, we could be speaking more an hour or two about those topics, because that is a very unique opportunity for us. So we're very thankful for you guys to being here with us today.
Thank you, everyone. That was amazing, fantastic. Really, lots of work to do, right? That's what all good about this kind of activities. So thank you very much. That was fantastic to have different perspectives, and let's get on strengthening our clinical pharmacy for transplant. Thanks for all the people from other institutions, right, particularly here in Brazil, that have joined us. We truly believe that, right, as a community, you're going to make much more of a difference than, right, just by an individual institution, because there's lots of work to do. We'll try to, right, be supportive as much as we can, because we're truly believers that pharmacy can really change the outcomes, as we just mentioned, for our patients. Thank you very much.
Thank you all, guys.
Thank you so much for the opportunity. Thank you.
Thank you so much. It was nice meeting everybody.
Thank you.